Chapter 9 is over musculoskeletal system disorders. The skeletal system provides support for the body. The skeletal frame determines the basic size and proportions of the body, and bone provides protection for the viscera, like the heart and lungs, as well as for other structures like the spinal cord and the brain. Bone also has other functions like calcium metabolism and storage, and bone marrow, which is where hematopoiesis takes place. This is the production of blood cells. Bones are classified by shape. We have long bones that have long hollow shafts or a diaphysis with two bulbous ends or epiphyses. We have short bones that are kind of square in shape and flat bones that are thin and can be curved. When I'm talking about flat, they're just thin, kind of like flat structure. Like I said, they can be curved. And we have irregular bones that vary in shape. They have projections or points. So bone is a connective tissue that consists of an intracellular matrix that's made up of collagen fibers and calcium phosphate salts. Haversian systems, or osteons, are the microscopic structural units of the matrix. And bone cells, osteocytes are mature bone cells, osteoblasts are bone-producing cells, and osteoclasts are bone reabsorbing cells. There's two types of bone tissue. Compact forms the outer covering of bones. It's a bunch of tightly packed Haversian systems. Cancellous or spongy forms the interior of bones, so it's less dense and more porous, and it does not have the Haversian systems. There's also the periosteum, which is the connective tissue that covers the bone, and the endosteum, which is the lining of the medullary cavity. This is the bone marrow cavity. This area is full of osteoblasts. This picture and the one from the last slide are on page 164 of your book. Skeletal muscle has four main functions. It facilitates body movement, it maintains body position, and it stabilizes joints as well as producing heat. Skeletal muscle is under voluntary control, which means that we consciously control that movement. There are some things that we kind of do automatically, like breathing, blinking, or shivering, but these are all things that we could control. Skeletal muscle consists of bundles of fibers, muscle fibers or cells, covered by connective tissue. It's striated or striped, and it results from the arrangement of the muscle fibers. It's well supplied with nerves and blood vessels. The muscle is stimulated at the neuromuscular or myoneural junction, where the end of the motor nerve and the receptor site in the muscle fiber is located. During exercise, the blood vessels in the muscles are dilated to promote greater blood flow into the muscle, increasing the supply of oxygen and nutrients. Myoglobin is an oxygen-binding protein similar to hemoglobin that stores oxygen in the muscle fibers. Glycogen is a source of glucose and is also stored in the muscle fibers. Muscles can be directly attached to the periosteum of a bone or by a tendon that connects two bones that articulate at a joint. Skeletal muscles don't undergo mitosis after birth. They undergo hypertrophy. This is increasing the size of the muscle when the demands are increased, like with regular exercise. And the opposite of hypertrophy is atrophy. This is where the muscle size is decreased, like when it's not being used. Like, have you ever heard of, like, if you don't use it, you lose it? So this is true for muscles. They actually shrink in size if they're not being used. And joints or articulations between the bones are classified by the degree of movement they allow. Synarthroses are immovable, like the sutures in the skull. Amphiarthroses are slightly movable. They're connected by cartilage, like the ribs, to the sternum. Diarthroses, or synovial joints, are freely movable, like the shoulder or the hip. And then we have the articular cartilage. This is what covers over the ends of the bones. The synovial membrane produces synovial fluid that fills the space between the ends of the bones. The articular capsule consists of a synovial membrane, a fibrous capsule, and ligaments reinforces the capsule, links the bones, and supports the joint. Menisci are lateral pads in some joints to help stabilization. And bursa are fluid-filled sacs to kind of add as a cushion. If we suspect musculoskeletal problems, we can diagnose this a few ways. For bone problems, we use radiography or bone scanning. For muscular problems, we use electromyography or EMG, or we can take biopsies. And for joint problems, we use radiography, arthroscopy, MRI, or we examine the synovial fluid. So a fracture is a break in the integrity of a bone. Fractures happen because of trauma, neoplasms, which are tumors, or increased stress on the bones. Your book says that fractures are charted using the number or pound sign. I've never seen fractures charted that way. I've seen them abbreviated as FX, though, and you might see that FX. There's lots of classifications of fractures. Most of them are pretty self-explanatory, but make sure you're familiar with them. They are on page 169 in your book for pictures. A complete fracture is a broken bone forming two separate pieces. Incomplete is a bone that's only partially broken. An open or compound fracture is when the skin is broken. Closed is when the skin is not broken. Simple means a single break, there's alignment, there's good positioning still. Comminuted is when we have multiple fractures in bone fragments. I think of comminuted as like a shattering type of fracture. And then compression is when bone is crushed or collapsed into small pieces. Transverse is a fracture across the bone. Linear is a break on the axis of the bone. Oblique is at an angle. Spiral is a break that angles around the bone, like a twisting injury. Don't worry about the Colles fracture and the Potts fracture when you're studying, though. Impacted fractures happen when one end of the bone is kind of telescoped into the adjacent bone. Pathologic fractures happen when the bone is weak from conditions like tumors or osteoporosis, and the bone just happens very easy, or the break in the bone happens very easily. Stress fractures happen when there's a repeated excessive stress on the bone. Depressed fractures happen in the skull when the broken section is forced inward and pushes on the brain. When a bone breaks, bleeding begins from the blood vessels in the bone and the tissue around the bone, the periosteum. Bleeding and inflammation also develop around the bone because the soft tissue damage causes, and this ends up causing severe pain. Chemical mediators are released and a hematoma or clot forms at the fracture site. Some systemic signs of inflammation might also occur. The picture here shows the healing process of a bone fracture. It is on page 170 of your book. Look it over, but don't worry about memorizing it. So there's a lot of things that affect the healing process. In kids, bones can heal in about a month. In adults, it takes more like 2 months, sometimes even longer, especially if it's an elderly person. Bone healing can be affected by the amount of damage done to the bone and the site around the bone, the proximity of the bone ends, and by that I mean like the gap in the break. So if your bone pieces are close together, it's going to heal a lot faster than if it's out of place. The presence of foreign material or infection, so a closed fracture usually heals faster than an open one because once it's open, there's a chance for foreign material to enter and infect the area. Blood supply to the site of the break, and systemic factors like age, nutrition, anemia, things like that. Some complications include muscle spasms, infections, ischemia, fat emboli. This is when the fatty bone marrow escapes from the bone into a vein. The fat can travel to the lungs and it can cause an obstruction, inflammation, respiratory distress, severe hypoxia. Nerve damage can also happen when we have a break. Trouble healing or deformities can happen, and fractures in or near joints can have long-term effects like osteoarthritis, or if we have a child whose growth plate is damaged, it can actually stunt their growth. Immediate splinting and immobilization of the fracture is important. This helps to minimize the risk of complications. Reduction of the fracture can be performed to restore the bones to their normal position. Closed reduction is using pressure and traction to put them back into position. Open reduction is a surgery to align the bones, and we use pins, screws, rods, or plates to keep them in place. Compartment syndrome is another complication of fractures. It happens when there is more extensive inflammation. Increased pressure of the fluid within the fascia, or that non-elastic covering of the muscle, compresses the nerves and blood vessels, causing severe pain and ischemia or necrosis of the muscle. Dead tissue can become gangrenous, requiring amputation. This can be caused by a tight cast. This is why if you go in with a broken bone, they want the swelling to go down before they cast it. Dislocations are the separation of two bones at a joint with a loss of contact between the articulating surfaces. Usually one bone is out of position while the other stays in its normal position. There's usually a lot of soft tissue damage to the surrounding ligaments and tendons. You can usually tell there's a dislocation because the joint is distorted. When I dislocated my kneecap, it was like on the side of my knee. Once a joint has been dislocated, it's more susceptible to dislocate or pop out of place repeatedly and can end up requiring surgery. A sprain is a tear in a ligament, and a strain is a tear in a tendon, so you should know the difference between the two. Then we have avulsions. An avulsion is when the ligaments or tendons are completely separated from the bony attachments. When we have any of these, immobilization is usually used to prevent tissue damage and to help the healing process. Ligaments and tendons are not very vascular, so they do take a long time to heal. Some other joint injuries are overuse injuries like muscle tears, repetitive strain injuries that happen from repeating the same movement over time. These can happen as a result of trauma or overextension or overstressing of the muscle. Repeated injuries will result in fibrous scar tissue replacing the normal structures. There's 3 degrees of muscle tears. First degree is a small percentage of the muscle fibers. Second degree is a lot of the muscle, but not a complete tear. And then third degree is a complete tear across the width of the muscle. To treat joint injuries, we use what we call RICE. Rest, ice or immobilization, compression, and elevation. We also use NSAIDs, physical therapy, and massage. And then on to bone disorders, or more bone disorders. The first bone disorder that we're going to talk about is osteoporosis. There's a couple picmonics about this in your modules. Osteoporosis is a decrease in bone mass and density that causes weakness of skeletal strength. Primary osteoporosis includes postmenopausal, senile, or idiopathic osteoporosis, and secondary affects men and women as a complication of some sort of other disorder. Bone is continuously remodeled, and osteoporosis happens when bone reabsorption exceeds bone formation, so it leads to thin, fragile bones that are easily fractured. At first, there's no symptoms, but it can be diagnosed with bone density scans. Common fractures are of the vertebra and the hips. So some predisposing factors, age 50 years or more, decreased mobility or a sedentary lifestyle, hormonal factors like excess corticosteroids or parathyroid hormone, a deficit of estrogen or testosterone, deficits of calcium, vitamin D, or protein, cigarette smoking, a low BMI, Asian or European ancestry, and excessive caffeine intake. So to treat it, we use dietary supplements. We recommend weight-bearing exercise, PT, physical therapy to reduce pain and to maintain function, bisphosphonates, it's just a drug class, calcitonin, and the human parathyroid hormone, different meds. Then we have rickets and osteomalacia. So these result from a deficit of vitamin D and phosphates. It's usually because of a dietary deficit or malabsorption, because if we're not absorbing well, then it doesn't matter what you eat, it's not going to make a difference. Or the intake of phenobarbital, which is a medication, or the lack of sun exposure. If we have this in kids, it leads to weak bones and other skeletal deformities. In adults, it might lead to soft bones, so you might see more like compression fractures. Then we have Paget's disease. This happens in older adults, like older than 40. The exact cause has not been established, but it does involve bone destruction that is replaced by fibrous tissue, and pathologic fractures are common here. In the vertebrae, it can result in compression fractures and kyphosis. And in the skull, it can cause increased pressure and result in headaches and compression to the cranial nerves, which would mean severe pain for your patient. Then we have osteomyelitis. It's a bone infection that's usually caused by bacteria, sometimes fungi. The microorganisms can enter the blood from an infection anywhere in the body and spread to the bones. It can also happen as a result from a foreign body entering the bone, like when pins are inserted in surgery. Signs and symptoms can be local and systemic. And we treat with antibiotics, and sometimes surgery might be necessary to remove the foreign device. And there's 3 abnormal curvatures of the spine. I mentioned kyphosis a little bit earlier. Kyphosis is a hunchback. It's an abnormally rounded upper back. Lordosis is curving inward of the lower back. Think like, oh Lord, my back hurts. This lordosis is usually what we see in like pregnant women that kind of lean, forward with their belly. And then scoliosis is the S or C-shaped sideways curve of the spine. And these are all illustrated on page 175, well, for kyphosis and lordosis in your book. And let me see if there's... And I actually don't see a picture of scoliosis in your book, but kyphosis and lordosis are in on page 175. I do have some picmonics about these in the module. Most bone tumors are malignant. Bone is a common site of secondary tumors from breast cancer, lung cancer, and prostate cancer. Osteosarcoma is the most common primary neoplasm or tumor of bone. It happens in the shaft of the long bones, like in the leg, and it's common in kids and young adults. Bone pain at rest is a big warning sign of this. The problem with that is that a lot of kids have bone pain while they're in their growing stages, so it might go unnoticed. It might just be thought of as growing pains. Chondrosarcomas arise from cartilage cells, more common in adults, and Ewing sarcoma is common in adolescents and usually happens in the shaft of long bones. So make sure that you're able to differentiate between those different bone cancers. Bone tumors metastasize or spread to the lungs very early. We treat them by excising or removing them if possible. If it isn't possible, we can amputate the limb that it's in, and then we'll use chemo to reduce the mets. There's also picmonics about muscular dystrophy in your modules. Muscular dystrophy is a group of inherited disorders characterized by the degeneration of skeletal muscle. Duchenne's is the most common type. It affects mostly young boys. The pathophysiology is a metabolic defect, a deficit in dystrophin, which is a muscle cell membrane protein, that leads to degeneration and necrosis of the muscle cell. Skeletal muscle fibers are replaced by fat, and connective tissue and muscle function is gradually lost. Signs and symptoms include a motor development delay, a waddling gait, difficulty climbing stairs, and goer's sign, as well as reduced tendon reflexes, deformities like kyphoscoliosis, which is just a combination of kyphosis and scoliosis, respiratory infections, and sometimes cardiomyopathy. Diagnostic tests include identification of genetic abnormalities, elevated creatinine kinase levels, electromyography, muscle biopsy, and then blood tests that would show the abnormal dystrophin levels. To treat it, there's no cure available, so we just work on treating the symptoms. Moderate exercise can help maintain motor function. We use supportive appliances like walkers and braces. Physical therapy and occupational therapy to maximize function and adaptation to new devices, massage to reduce pain and stiffness, and eventually, if there is a respiratory failure, then maybe a ventilator would be necessary. So this is on, gosh, no, I'm not going to be able to find it. Oh, sorry, this is on page 176 in your book. You can take a look at it. You don't need to know anything but Duchenne's. That's what I'm going to ask you about on your exam. Then we have fibromyalgia. So fibromyalgia is kind of called like a disorder that we kind of rule everything out. So it's a diagnosed by rule out. We can't definitively diagnose it based on any signs and symptoms. We just rule out a bunch of other stuff and then end up with fibromyalgia. that's characterized by pain in the soft tissues, stiffness that affects the muscles, tendons, and soft tissues. There's no obvious inflammation or atrophy. It can lead to sleep disturbances, severe fatigue, and anxiety and depression might be present. Again, we don't know the exact cause, but it's thought to be some sort of imbalance actually in serotonin and other neurotransmitters, and an increased production of that substance P, which has to do with pain. Some predisposing factors are women aged 20 to 50 years old, history of physical or psychological trauma or chronic pain, sleep deprivation, stress, and fatigue. And to treat it, we want to teach them to avoid stress as much as possible. Actually, a lot of times we will put them on some sort of antidepressant to help, to help with that. Regular exercise, especially in the morning, activity and rest kind of paced as needed, using heat or massage to painful areas, analgesic drugs, NSAIDs, and there's also some other drugs out there like Lyrica that will help with it. And then on to joint disorders. So osteoarthritis is a degenerative joint disease. Degenerative means it's a wear and tear joint disease. It could be the result of increased weight bearing or lifting. The incidence is increasing. There is potentially a genetic component that goes along with it. The pathophysiology includes the articular cartilage is damaged. Surface of the cartilage becomes rough and worn. Tissue damage causes a release of enzymes that accelerate the disintegration of that cartilage. The subchondral bone might even become exposed. We might develop cysts, osteophytes, or new bone spurs. Osteophytes and cartilage might break off and the joint space becomes narrower. And then that osteophyte and cartilage breakoff can lead to secondary inflammation of the surrounding tissue. All of this will lead to a loss of normal range of motion and pain with weight-bearing exercises and even use of the joints. The primary cause is from weight-bearing, or the primary form is caused by weight-bearing activities, obesity, and aging. And normally we say, we promote weight-bearing activities, but I'm talking about excessive weight-bearing activities. The secondary form follows a trauma or repetitive use. Genetic factors are thought to play a role in this. The weight-bearing joints are the most frequently affected joints, but finger joints could also be involved. Signs and symptoms are aching pain with weight-bearing exercises and movement, joint movement that is limited. Recreational and social activities become limited because of this pain. Walking becomes difficult. They're more likely to fall. And then in temporomandibular joint, or the TMJ, we have TMJ syndrome. So mastication or chewing and speaking become difficult. We can also see bony enlargements of the distal finger joints. To treat it, we want to minimize the stress on the joint, use adaptive devices as needed, like a cane. We can do activity, but we want to pace it at their level. Mild exercise programs, because we want to maintain fitness and joint function, but again, we have to pace that. And then supports like hand braces that help facilitate movement, maybe even orthotic inserts in the shoes, whatever assistive devices they need. We can also do massage therapy, physical therapy, acupuncture, occupational therapy, glucosamine and chondroitin supplements. We can inject synthetic synovial fluid. We can use NSAIDs, analgesics, arthrotomy to stabilize the joint, and maybe even surgical joint replacement if it becomes severe enough. Then we have rheumatoid arthritis. This is considered an autoimmune disorder. Autoimmune disorders are when the body attacks its own cells, recognizes them as foreign, and attacks them. It causes chronic systemic inflammatory disease. It's a higher incidence in women than in men, and it affects all age groups. The pathophysiology is synovitis with marked inflammation and cell proliferation. A pannus forms, P-A-N-N-U-S, where granulation tissue called pannus spreads over the articular cartilage and releases enzymes and inflammatory mediators, destroying the cartilage. Then the cartilage erosion happens. It's eroded by the enzymes that create and it leads to an unstable joint. Fibrosis. In time, the pannus between the bone ends becomes fibrotic and limits movement, and it calcifies, obliterating that joint space. And then we have ankylosis, which is joint fixation, and the deformity develops. Other changes frequently around the joint are atrophy of the muscles, the bone alignment shifts, and muscle spasms caused by inflammation and pain, as well as contractures and deformity that could develop. This is on page 181 in the book. It shows the deformity of a hand with rheumatoid arthritis. Some systemic effects are marked fatigue, depression, malaise, anorexia, a low-grade fever, iron deficiency anemia that's resistant to iron therapy. Again, when I say malaise, that's a general blah feeling. And anorexia, when I talk about that, it just means a general loss of appetite. The cause is not known. There is thought to be a genetic factor and a familial predisposition, and there are some possible links to viral infections. Signs and symptoms are affected joints that are extremely painful, stiffness of the joints, redness and swelling of the joints, that joint involvement. The joint involvement is usually small joints. It's usually bilateral, so both sides, both hands. The joint movement is impaired, and eventually the joint becomes fixed and deformed. Some systemic signs are fatigue, anorexia, mild fever, generalized lymphadenopathy, and generalized aches. To treat it, we balance between rest and moderate activity, hot and cold applications, physical and occupational therapy. We can use NSAIDs, glucocorticoids if the inflammation is severe, analgesics for pain, or analgesics for pain. We can use DMARDs like methotrexate and hydroxychloroquine as well. The biologic response modifying agents like infliximab, rituximab, and anakinra. It just really, depends on how bad it is for the patient. Then we have infectious arthritis. This is also known as septic arthritis. It develops in a single joint. The joint will be red, swollen, painful, and have decreased movement. And it's caused by direct introduction of bacteria into the joint, like trauma. Or we see this a lot in people that keep getting injections into a joint. So it could be a non-sterile injection, or they could be from surgery, or they could be a secondary infection because of bacteremia or bacteria in the blood. We treat it with antimicrobials over a sustained period of time, and these are usually IV. Then we have gout, also known as gouty arthritis. It results from deposits of uric acid and crystals in the joint, causing inflammation. They form in gout. You'll see the formation of tophus or tophi. These are large, hard nodules of uric crystals. Tophi cause local inflammation, and they happen after the first gout attack. So uric acid crystals form because of an inadequate renal excretion, or from chemotherapy, or from a metabolic abnormality, or from genetic factors. The inflammation causes redness, swelling, and pain, and it's treated by reducing uric acid levels with drugs and dietary changes. We diagnose it by examining the synovial fluid and blood tests. Use of NSAIDs prior to blood tests, though, will cause a false negative result, so it's important to know that with your patients. Then we have ankylosing spondylitis. This is a chronic progressive inflammatory condition. It affects the sacroiliac joints, the intervertebral spaces, and the costovertebral joints. It's more common in men 20 to 40 years old. The cause has not yet been determined, but it's thought to be some sort of autoimmune disorder with a genetic basis. So the way that it progresses, the vertebral joints become inflamed, and then there's a fusion of the joints with loss of mobility, inflammation in the lower back, then it kind of leads up the spine. Kyphosis develops, and then osteoporosis is common, and this all makes lung expansion limited. Think of it, that kyphosis, that hunchback, kind of compressing or causing pressure on the lungs. Signs and symptoms: lower back pain, morning stiffness, pain when lying down, and the spine becomes rigid. Systemic signs are fatigue, fever, weight loss, and uveitis. It's treated by drugs to relieve pain, daily exercise, physical therapy, and occupational therapy. And this is a good picture of that ankylosing spondylitis. This is on page 183 in the book. And some other inflammatory joint disorders: We have bursitis. This is inflammation of the bursa associated with bones, muscles, tendons, and ligaments of various joints. It's most common in the it's most commonly because of repetitive motion of a particular joint. To diagnose this, we can do a physical examination, ultrasound, or MRI. And to treat it, we just use rest and anti-inflammatory drugs, nothing super special. Synovitis is inflammation of the synovial membrane. Movement of the joint is restricted and pretty painful. To diagnose it, we'll see a red, swollen, and warm joint. We could also analyze the synovial fluid for signs of infection. To treat it, again, anti-inflammatory drugs. And then if there is an underlying treatment or an underlying cause, we would need to, remove that, identify it, and treat it to help get rid of the synovitis. And then last, we have tendinitis. This is irritation or inflammation of the tendon. The signs and symptoms are dull aches and mild swelling of the area. It's caused by a single trauma or possibly repetitive movement of the area. Diagnosis is just by physical exam, and here we're going to use rice, the rest and ice, pain relievers like anti-inflammatory drugs, as well as potential physical therapy. And that is it for this chapter.